Hi guys, welcome back. And last time we were talking about the ventricular rhythms. We were talking about PVCs. Now it's time to move on to the main events here. And again, these are all ventricular rhythms. And I want to stress the point of, yeah, they're all ventricular in origin. Usually these are going to be the wide and bizarre or kind of crazy ones. So ventricular tachycardia, okay? So remember, our intrinsic rate, by the way, our intrinsic rate of our ventricles was what numbers? It was 15 to 40, okay? I want you to keep that in mind as we begin talking about all this stuff. When we get into 12 leads, by the way, we're going to take a much deeper dive into ventricular tachycardia. And more importantly, how people miss it, okay? And yes, they do miss it. So we need to understand about our cardiology and how this works. What happens is in ventricular tachycardia is you get an irritable focus somewhere down here, okay? Somewhere in the ventricles, something's happened where it's either damaged or there's something poking it or something is causing the irritability that is firing it off. Your heart rate is somewhere in the 150 to 250. I've seen a VTach actually be like 50 beats a minute. So technically it can be that, okay? It will the rhythm will progress to ventricular flutter, but again, usually it stays constant in speed and constant in shape, and again, it's wide and bizarre. There's no P waves that you can visibly see. So again, if you're looking at this, boy, it's big, it's tall, it's wide, oh boy, okay? Now notice, however, it's not really changing shape, okay? And that's kind of important to note on monomorphic ventricular tachycardia, and there's a reason I say it like that, because there is such a thing as polymorphic ventricular tachycardia that we're going to go over here in a minute. Again, but stop and think about this. This is the ventricle spot that continues just to fire off. This is a lethal arrhythmia. Even if the person is sitting there talking to you with a good blood pressure, it won't be that way for long. Okay, they can't sustain it. All right, this person is in a lethal rhythm. They will eventually die from it. All right. With that being said, you can't stress the importance of taking care of this problem. All right, and this is what we do. This is how we do it. Okay, so again, VTach. These guys can have a pulse. They can be sitting there talking. They can be sitting there arguing with you. There's many calls I've had. People absolutely refusing to go to the hospital, and I said, well, what were we having for dinner? And he's like, what? I said, yeah, I'm going to stay here till you pass out. So hey, what do we have? You were cooking dinner. What are we having for dinner? And they'll look at me like I'm crazy, and I'm like, look, I'm not leaving. You're going to eventually fall out. When you do, I'm taking you to the hospital. Matter of fact, I'm going to shock you and take you to the hospital. I said, here's the deal. Right now, I can still treat it with medicine because you're sitting there talking to me. So it's really important to understand that. And the thing that we really need to ask here is, number one, do we have a pulse? Okay? Very important. So if I see this rhythm, I need to know right away, do I have a pulse? If I do, yay, we got some more things to do. Okay? If I don't, then I need to defibrillate them. Okay? I need to defibrillate them. Now, if they do have a pulse, now I just need to know whether they're stable or unstable. Okay? That's the next question I'm going to ask. And again, remember, if they got the cash, that means that they're unstable. And if they got the cash, they get the jewels, right? So again, and by the way, that's going to be a cardio version. I'm going to put a little C on top of that. We're going to time that defibrillation. If they are stable, we're going to use medication. Now, the meds that we use on VTach, hey, guess what? It's the same ones we used on the PVCs. And it's the same ones that we're going to use in Vfib. It's the same ones, the ventricular antidysrhythmics. Those guys, amiodarone, lidocaine, procainamide. Sotalol is actually gaining some traction. Sotalol is a type of beta blocker that actually works pretty good on it, on a ventricular tachycardia. But your mainstays, guys, is the amiodarone and the lidocaine, especially the amiodarone, okay? And stop and think about it. what happens if I remember this cardiac action potential thing that we studied a little bit? We were talking about physiology, and what happens in sodium or the potassium channel blockers is actually we kind of move this out. Okay, remember that from our physiology. Well, actually, that's kind of a good thing, because what that does is it helps everything reset, and it allows for the ions to change. Sorry, guys, my pen is acting up. So your potassium actually shifts it this way, which causes more of the ions to exchange. Your calcium and your sodiums are going to exchange more, and because of that exchange more, it's probably going to bring them out of this rhythm, or have a chance to bring them out of this rhythm better. Okay? So again, when we have VTAC, do they have a pulse? If they don't have a pulse, we're going to treat it just like Vfib. If they do have a pulse, I need to know whether it's stable or unstable. If they're unstable, they got the cash, they get the jewels, right? Crushing chest pain, altered mental status, severe shortness of breath, or hypotension. Any one of those four, okay? If they're sitting there pale, cool, and sweaty, their blood pressure is 160/90, and they just simply can't catch their breath. Guys, that's good enough for me, okay? To be blunt, that's very good enough for me, okay? They're showing physiological signs of instability. Remember, I kind of made a big deal about that when we were talking about tachycardias. I'll make it even a bigger point here. When in doubt, in the patients in VTAC, when in doubt, you probably need to cardiovert them, okay? Now, next one is Vfib. So what happens here is the heart actually starts to quiver. Is the best way. There's no discernible organization. You're not going to have Vfib with a pulse. I don't care how. But if you've got Vfib with a pulse, check your cables because something's off. Okay. Again, it will not produce a pulse. So again, a reminder here. Again, it's quivering. There is no movement of the ventricles. Okay, no movement. That's the key thing. The way we fix this, guys, is we cardiovert it, okay? We don't cardiovert it, we defibrillate it. We absolutely 1000% defibrillate this, okay? We need to provide an electrical reset to the heart. All right, so there is no anything recognizable. It is squiggly line, okay? There you go, Vfib. Now, by the way, Vfib can be a lot of other things. It can be coarse, it can be thin. There's different shapes that it can be, okay? We'll use those terms to kind of define and see it. Going back down here to my pen. If I've got a Vfib, this is kind of a standard Vfib here. But again, I can have Vfib. Dagnabbit. Let's go back here. Find my pen. Give me my pen. Give me my pen. There you go. All right. So again, if I got it really tall and really crazy, and it's doing this, again, and we will call that, and I would actually call it coarse Vfib. And the other end of that is you got a really tiny and it's really fine, and that's what we call it is fine Vfib, okay? And a lot of people will confuse fine Vfib with asystole, okay? So again, and then we'll talk about asystole, how to check it real quick. But again, if I've got a little bit of quiver, I will tell you this: the more quiver I've got, the better chance I've got of getting them back. Okay, so what we do in our ACLS algorithms and protocols is, if we have something down here like this, we try to give them epinephrine, antiarrhythmic drugs, to hopefully put them back into this type of a fib, so that we can perform a counter shock, and it will be more effective of counter shock. Okay, if that doesn't work, then we will give them the antiarrhythmic drug, try to maybe change some of those the cardiac action potential, so that the chances of us getting the patient back will be more successful. All right. So again, that's Vfib. If we see this, you can check for a pulse. We should not have a pulse. We don't have a pulse. Defibrillate it, defibrillate it, defibrillate it, defibrillate it. Don't wait. Don't do 2 minutes to 4 minutes of CPR. Got wonderful studies on that kind of said, it probably doesn't work. the risk outweighs the benefits, and American Heart came out with a stance of if you see Vfib, defib. And that's the little thing that you should remember. If you're seeing those squiggly lines, again, the patient's unresponsive, no signs of life, start compressions while you're getting your pads on, and then let them have it. One other thing about this, don't forget to do your compressions, okay? As dumb as that sounds. I've seen people work entire codes without doing the first bit of CPR. We gotta circulate the blood around still, guys, okay? Remember, kind of the tenements of EMS. Air goes in and out, blood goes round and round. That hasn't changed. All right. Idioventricular rhythms. Now, this is where, in the absence of one of the higher pacemakers, the ventricles initiate the electrical impulse for you. Remember, we talked about this, 15 to 40 beats a minute, or again, 20 to 40 beats a minute, depending on which book you read, okay? I'm good with 15 to 40. There are no P waves, and then you've got a wide, bizarre pattern. But notice how this has got wide and bizarre. Now, before you ask, no, that is not a P wave. That is actually part of the idioventricular process. Okay, so again, it's coming from some spot down here in the ventricle. By the way, a little sidebar: if you give this person amiodarone or lidocaine, you will kill them. Okay, so therefore, don't break those drugs out. Now, obviously, this is going to be a slow heart. You're going to get no atrial kick. You're going to get a lot of no squeeze coming from the atria, and you're going to have a really limited cardiac output. Yeah, this is really no bueno here, okay, guys? This is a really bad rhythm for the person to be in, and we really do need to speed this up just to keep the cardiac output going with this. By the way, your atropine is useless in this situation. You need to use a drug that's going to affect the bottom part of the heart, or you're going to need to pace it, okay? And again, in the emergent setting, 2 pads are really quick and easy to put on, okay? And then you might be thinking about using your epi or your dopamine. But usually, by the way, if you've got this situation, that means that both your SA node and your AV node have failed. So you probably got a massive heart attack going on down there. And now we're going to ask it to pump all of this area down here to pump harder. Ooh, okay. As you can see, it's going to be a long day at the office. All right? So idioventricular, wide, bizarre, but regular. Notice that this is a regular rhythm, okay? Most of the time they are regular, all right? Whatever you do, these aren't PVCs. Don't kill them, okay? Because if you try that, you're going to kill your patient. One day, I have some bad news for you guys. You're going to end up in this rhythm. You are going to end up in asystole. Every one of us are going to do it. It's going to happen. It's okay. All right? It's called dead. All right? So, again, there's nothing going on, gang. There is no electrical activity at all, okay? None. Zilch. Nada, okay? There is nothing on. Elvis has left the building, okay? He's done. Now, the one thing I'm going to say is this is the only lead that I would say confirm in 2 leads, okay? So this is the guy that we want to take. Remember, we look at lead 2 normally. This is the guy I might actually take a look at. Maybe, I don't know, I would probably even not do lead 3. I would probably do like lead 1, where you got your positive up here, so that I'm looking across this way as well as looking this way, okay? And the reason that I do that is I want to make sure that I don't have that, again, fine Vfib, okay? But because of the camera angle, it looks like this, okay? So that's why we always confirm asystole in 2 leads. Make sure that you do that. The bad news is here, guys, is so with Vfib, VTAC, we perform electrical reset. I use the analogy, you're trying to reset a computer that's not even plugged in, okay? There's no electrical activity here. So you can shock this all day long, and it's not going to do anything. Matter of fact, one of the side effects of defibrillation is that you can put them into asystole. You can stun the heart. So you can actually put them where they have no electrical activity. So yes, there is a danger to performing a cardioversion or a defibrillation. The risk is quite low, but it can do that. You can actually stun them into this rhythm, okay? And again, it kind of makes it makes things a little bit tough. The only thing you can do at that point is to find any reversible causes and continue to give them epinephrine, okay? And by the way, if you haven't started learning these yet, you need to start learning them, the H's and T's, okay? And we're going to go over H's and T's in another video because those are kind of important that we go over these as we start to treat these particular rhythms. All right. Now the good news is by the way, this is known as P-wave asystole, which kind of contradiction in term. It's also known as ventricular standstill. What happens is I got P waves, I got P waves, I got P waves, but I have no QRSs. This is a true, complete heart block where the ventricles aren't moving. Okay, so what's happening is we got our heart up here, and then this guy fires off and goes to the AV node, but something has happened in the AV node and it's not letting any signals through. So conventional wisdom is well the ventricles should take over. Well, in this case, the ventricles are not taking over. So instead of seeing that beautiful third-degree heart block that you would expect to see, you're now seeing zilch. Okay? Zilch, none, nada. If you do see P-wave asystole, you can try to pace that. I don't know how effective it would be, but at least you can try it because you know that there's not you've got no signal going down to the ventricles. If you provide signal, that might be okay. With me saying this, by the way, in the olden days, we used to pace this. Here's the problem with doing that. You're trying to squeeze water out of a stone. Okay? Again, asystole pacing has not shown any benefit. Where this guy here, unless there's an underlying rhythm, the guy drank a bunch of organophosphates. That would be maybe my only, or took a lot of beta blockers. Maybe I would think about performing a pacing in that situation. But this right here, nah, pacing's not going to help. You're going to send a signal, but the ventricle's just not going to move. Okay, it will not. So again, you're wasting your time by doing it. Epi, good CPR, figure out what's wrong and fix it. If you can fix it. This guy right here, pacing may be a little bit more effective. I would probably go the epinephrine route first and try to see if that worked. Last but not least is the agonal rhythm. Again, it's usually determined somewhere less than 20 beats a minute, or if it makes you feel better, less than 15. Sorry, so less than 15 a minute. Let's scratch out the 20. Let's make it 15. It might be as high as 20. This is a dying heart. There's no P wave. There is a super wide QRS, kind of waves into the T. Okay, this is what is known as a dying heart rhythm. You definitely see this. Let's say we have a beheaded patient, and you get there and you throw them on the monitor. I don't know why, but you throw them on the monitor, and there's still a little bit left. The heart's trying to beat, but again, there's no control. The heart's doing what it thinks it needs to do, which is try to squeeze. Okay, the heart has stopped beating in a reliable pattern. It's also called the dying heart. It can be regular. Most of the time it's not. It beats when it wants to. It thinks it needs to beat. Again, they usually are not pulse producing. It kind of depends. Sometimes they are, sometimes they're not. Most of the time they are not. And it's found again with that patient who is on there. It's a last gasp effort by the heart. All right, so that covers all of them. And again, you got practice strips on Canvas where you can pull these up, take a look at them yourself. Again, you should be a sinus rhythm with unifocal PVCs. Here we go. By Gemini. Let's see here. Sinus with a unifocal PVC, VTAC. Trigemini, but they're unifocal. Vfib. Shock at defib. Holy crap. Not only do I've got sinus rhythm, but I got unifocal PVCs with a run of VTAC. Good gravy. That is a long one, right? So we got a bunch of things going on here. Unifocal PVC, unifocal. Well, Scott, it's taller. It's the same shape. It's coming from the same spot probably. But then you got this guy right here. Whoa, 4 of them. Yeah, that's a nice big couplet. I would say that that's VTAC. I would definitely get a 12 lead on it, and I'd see how my patients do it. Multiform VVCs, VTAC. Unifocal PVCs, sinus looks like the base, VTAC. Bigeminy, coarse Vfib. So guys, go through these, take a look at them, see if you can pick them out, see what the strips are, what you think that they are, okay, and give that a shot. And you saw when I started naming all those things, but that's how fast you should be able to name them at this point. Okay, you guys are going to take a little bit to get there, but again, you should be able to use those rules. It shouldn't take you long to figure out a ventricular rhythm. Wide and bizarre, okay? All right, that's going to do it for this video, and we will talk to you guys on the next one.